Hello, and welcome to the No Bad Questions podcast, where I try to learn in a conversational manner by sitting down with people who have interesting careers, important lessons to tell, or inspiring stories. I hope that you learn something too. If you want to support the podcast, please follow or subscribe on your platform of choice. You can also like or comment to boost the algorithms or share out to your network to make sure it gets more views. But ultimately, and what I hope you choose to do, is listen to the very end. With that, we'll start today's podcast. Hello, and welcome to this episode of the No Bad Questions podcast. My guest for this episode is Hawke. Hannah has a lot of letters after her name, which we will get into. MACCC-SLP-BCS-S. She is the Director of Therapy Services as well as the Department Coordinator of Speech and Language Pathology at Mary Rutan Health in Bellefontaine, Ohio. She earned her Bachelor of Science in Speech Pathology and Audiology at Miami University, her Master of Arts in Speech Language Pathology at the University of Toledo. Hannah enjoys working with young children who have feeding challenges with special focus on infant feeding difficulties. She received her credentials as a board-certified swallowing specialist in 2014 after completing a 3-year program that requires extensive education and training in the area of feeding and swallowing disorders. She owns a speech pathology company that provides speech therapy services to patients in the hospital setting as well as to local schools. In her spare time, all of it that she has, Hannah is working on program development for anxiety-induced dysphagia, a booklet for parents called Setting Your Kid Up for Feeding Success, and a guidebook for speech language pathologists who treat dysphagia in schools. With any time remaining she has left over, Hannah likes to adventure with her family, and she's taking care of 3 little old dogs. Hannah, welcome to the No Bad Questions podcast.
Hi, David. Thank you for having me.
So many people think of speech therapy, and they just think of maybe helping somebody with a speech disorder, helping somebody talk. So in the modern world, in 2023, when we're recording this, what is speech therapy?
Well, so the more technical term for it is speech language pathology. So that name at least incorporates the speech and language aspects of our field. Mm-hmm. So speech meaning more along the lines of like articulation issues, so pronouncing sounds and pronouncing words, and then the language aspect, so both receptive and expressive language issues. So I think that term at least encompasses those things. What it doesn't encompass is more of the swallowing or the dysphagia aspect of our field. There are also many other aspects of our field that aren't widely recognized, such as voice disorders, stuttering or fluency issues. And then we work with a lot of adults who have had issues post stroke or car accident and have sustained a traumatic brain injury. So we also work with patients who have a wide variety of progressive issues such as Parkinson's or ALS. So kind of working on more of that maintenance type therapy, making sure that patients are, able to keep their voice and their speech and their swallowing for as long as humanly possible with those diseases. So we do quite a few different things. So when you look at speech pathology, we kind of break it into adults and pediatrics. I know a lot about the adult world, but my focus is definitely on pediatrics.
Okay. And within that, just to continue level setting for listeners who may not be in the medical world and the clinical world, you mentioned dysphagia, and that was actually in your bio. Can you just, in a nutshell, explain to folks what dysphagia is? Because that's obviously a more medical term.
Sure. So dysphagia is kind of an encompassing term for feeding and swallowing disorders. Mm-hmm. There are lots of subsets of dysphagia, but that is kind of the umbrella term for swallowing difficulties. For adults, that more likely means challenges with liquids in general. For pediatrics, that's not always true.
Okay. Thank you for breaking that down. So it sounds like the terminology, speech therapy or speech language pathology, still isn't big enough. It's
No,
still too narrow. Do we need a new word? Do we need a new do we need a new term for your profession?
I wish. I wish we in this profession have thought about this a lot because there has to be a better way to define us that
Mm,
helps the public understand what it is we're capable of helping them with. So if right now the perception is that we help little kids say their R's and S's, they then people don't realize what we can do, and we can do so much more than that. But I don't know what that term would be. We've talked about this for years, and the whole profession, and we haven't come up with anything that works yet.
interesting. I'm not sure that's a nut that I can crack, but one that I can try to do. And why I asked you on today is exactly that, to spread awareness of what you can do for potential patients and families, particularly of young kids. I know that you and I have had some interactions professionally and personally in terms of helping my family, and so that was part of why I really wanted you to um, come on the podcast and talk to the dozens and dozens of listeners who will listen, and maybe they can carry that message out that there's maybe some options for young kids out there. So one of the things that has been amazing along that journey of working with you is how young of a patient you and your profession can help these days. I think a lot of folks don't realize. I mean, you're working with newborns, right? How young can your profession help people?
So there's a small group of us that work in NICUs. I
Hmm.
personally do not have any experience with NICUs, and that's not because I don't want to. It's because in the area that we live in, we do not have a NICU at our hospital. But in larger hospital systems, there are quite a few of us that work in the NICU with babies that, start out on a feeding tube because they are premature or
Hmm.
have challenges in other ways when they're born. So, right out of the gate, we start working with these little ones. Me personally, I start working with them once they are discharged from the NICU, hopefully. That's always my goal. I want them right away.
Hmm.
So as soon as if they're having swallowing issues and they were in the hospital for swallowing issues, the second they get discharged, I want to see those babies. So that's something that hasn't been kind of the trend in the last decade. We're moving that direction. We're working on faster identification of swallowing concerns in infants and getting them to me as soon as we recognize that. So, our pediatric providers here locally have really stepped up and have learned to screen these babies to get them to me within the first 2 months. So, that's definitely, a positive trend here that I'm getting these babies a lot earlier.
Okay, so is this pattern of your profession trying to get patients in sooner, but maybe the hospitals and doctors are stuck? 10 years ago, your profession seems like it's come a long way in the last 10 years. Is this something that your profession is struggling with more broadly to get the newborns in earlier, or is this a more Ohio thing since you and I kind of live and operate in Ohio? How broad is this?
That's a good question. I feel like when you look at pediatric feeding and swallowing programs, it's developed in the last 10 years, but not everybody is necessarily trained or comfortable in working with newborns.
Mm,
So I don't know that a lot of clinics even offer the newborn aspect of the feeding therapy programs. One other thing that's important to mention, because I just said, we're talking about speech pathology here, but we have an interdisciplinary program with occupational therapy. So I think it's
mm.
important to also note that most programs are either speech language pathology or occupational therapy or both.
Okay.
So for us, the speech language pathologist works with any human being from birth to 6 months. Once we hit 6 months, it's an interdisciplinary approach with occupational therapy. Now, that's
Okay.
just the way we do it. So, in other facilities, it could be a whole different setup. But I feel like as things have evolved, a lot of clinics have some good resources for children, but not necessarily for infants. So I think that that is something that is coming along, but I think it's going to be a few years before we have excellent resources in, in most outpatient areas.
And so this is an area that I'm ignorant of, and I'm not sure if you're well informed on it either. I mean, is this an area where, as a society, I feel like I read articles, particularly in Ohio, I think that even here in America, we struggle with infant mortality.
Me too.
And are these types of feeding issues a contributor to infant mortality? And do we need to specifically, laser in on, awareness of these programs? Today's conversation wasn't meant to be just about this. There's other things that I want to talk about today, but do we need to sort of double down on highlighting that if people have a child, have a niece, a nephew, a grandchild, or whatever, like awareness of this type of stuff, because obviously we want those babies to make it, So is this a major indicator for infant mortality?
In my opinion, it is.
Okay.
And I
Okay.
think if you talk to a lot of specialists that work with infants, they would agree. There are so many different trends that we are seeing in the clinical setting that I kind of wish I could direct some of the research studies that are going on because, like, for instance, it's very predictable for me now, and this is how I'm teaching my staff that I'm training to see in infants. One of the trends that we see that is very common is a child is born that has, some jaundice issues, whether or not it required treatment. It doesn't matter. It's just clinically significant. So, so jaundice issues, and then within the first couple of months, start having issues with food intolerance or ingredient intolerance, and that often presents as colic. Colic is a word that I don't like. It's an umbrella term for there's something wrong and we're not really sure what it is.
Hmm.
They'll grow out of it, so just kind of push through it.
Hmm.
And in my opinion, we need to problem solve what is causing those colic behaviors. So we're seeing that, we're seeing colic, we're seeing like lots of different skin issues. So whether that's like diaper rashes or eczema, that's very common to go with these things. We're seeing midline defects. So the most common midline defects would be like a tongue and lip tie,
Hmm.
which don't get me started on tongue ties because that's like one of my favorite subjects. And then often just seeing, all of these things put together. Oh, I forgot one, the addition of torticollis. There's
Okay.
5. So the addition of torticollis. So those 5 things clinically are very intertwined. And I think that the medical research is lagging in understanding what is going on genetically with these babies.
Hmm.
And I think that, as time goes on, environmentally, we're having a lot of changes. And I think that's affecting our genetics in general. And I think that this area of research is emerging, but I don't think we'll have the answers for another 5 to 10 years.
Okay. Okay. Um, so we're talking new babies up to 6 months. Let's age up a little bit. Let's say up to a year. And you
Okay.
talked about colic as this umbrella term, and you're not a fan of the term, but within that age group, what can new parents, like I said, grandparents, aunts, uncles, whatever,
Mhm.
what can a listener out there be on the lookout for that goes beyond, try to comfort the baby, the newborn, try to make them okay? What rises to the level of where it needs investigation? What can they be on the lookout for?
Sure. So, if we're talking individuals that are still drinking from a bottle, big red flags are feedings are taking more than 30 minutes.
Hmm.
So if a feeding is taking more than 30 minutes, the child is often burning more calories than they're consuming.
Hmm.
So that's a red flag. So one of the challenges is that when you look at the different bottle systems, there are different flow rates of nipples. parents don't really have any sort of guidance as to what flow rate is best for their child. So that can be problematic. And a lot of times you'll see it running out the sides of their mouth. So, what we call anterior bolus loss. So they're losing quite a bit out the front, so they can't get a good seal. That could be an issue that they're having with their oral musculature, or it could be just they don't have the right, nipple flow rate for them. So, let's see what else. So, spitting up is normal, and I think that's something that a lot of people are sometimes getting worried about. Spitting up is very, very normal because the esophageal sphincters are not tonically closed yet like they should be, and that's just normal development. But excessive spitting up or projectile vomiting is a concern. Along that same line, spitting up should not be painful. So what we talk about in our area is happy spitters. So if they're spitting up and they're still happy, leave them alone. But if they're spitting up and they're uncomfortable and it hurts, like that is not normal at all. So those are just some of the very basic red flags of when I can certainly help problem solve those things. I think for parents, it's very important to understand that there is a very important developmental window between 4 and 6 months to work on pre-feeding skills. And I don't think this is something that's necessarily widely known, but we need to be working on pre-feeding skills from 4 to 6 months. And there are lots of ways that we can help our children prepare themselves for consuming solid foods. So one of the most basic suggestions I have for parents is most of the teethers these days are circular. That's mostly for safety. And so a lot of the manufacturers have turned towards circular teethers just so that it's safer. And, if a parent leaves a child with a teether, the baby's not going to choke on it. So the thing is that keeps the teether in the front of the mouth, which I understand makes sense because you pop the teeth out and usually the bottom front 2 teeth. So that does make sense. However, if we don't have stick-like teethers, we're not able to start working on lateralization, so the left and right, using that tongue and that cheek to hold the teether along the molar surface to start working on kind of that phasic biting and non-stereotypic like munching pattern, which is what we need to start developing before we introduce solid foods. Additionally, these stick-like teethers will help push the gag reflex back, which is really important when we start working on introduction of solids. So I think my favorite time of an infant's life is when they hit that 6-month mark and we start introducing solid foods. I think that is where parents are very undereducated because I don't really know how to go about educating them. Like I said, I'm trying to write some sort of booklet or something that helps parents understand the basics of you need to have your feet grounded. So if you put a baby in a high chair where their feet are dangling, they have no real awareness of where they are in space and can't effectively focus on, what is actually challenging is oral control at that age. So it's little tips and tricks like that I'd like to figure out how to get the word out there for these little things.
So I'm sitting here thinking 2 things as I'm listening to you. 3 things. The first is that I hope the audience is still with us because we are talking about some pretty niche topics. But the second thing that I'm thinking about is you wish that kids came with an instruction manual. As a parent,
Yes.
it's a common wish, and specifically there needs to be a chapter on some of what you're talking about. I mean, even some of what you're talking about, I knew because I knew you, and my wife and I, had the opportunity to talk with you. But other things that you're talking about today, even still, I didn't know. And the thing about the teething, and so yeah, keep working on your booklet because it needs to be a thing that exists. And then the third thing that I'm thinking is I'm wondering, before the modern era, the cavemen, or not even back that far, just a couple few hundred years, what did parents do with babies for teething? They didn't have, plastic toys from Johnson and Johnson or whatever to give to their baby? Did they just chew on a stick? Like what?
I
I
mean,
don't. It, and we don't have to answer that. We're not anthropologists, but
right.
it's fascinating to me to think back even a couple hundred years out of the modern era. Obviously, there was much worse infant mortality back then, but in general, I wonder what they did because.
I would assume that a lot of babies chewed on their thumb or their fingers because babies still do that today. We, you know, babies that like to suck their thumb, we, try to break that habit. So we don't want them using it as a teether. I assume that that is something that they were using back in the day. Even babies now try to chew on, their mom's finger or whoever's holding them. A lot of times, like you put a knuckle in a baby's mouth when they're just chewing on it. So I assume that it was their own hands.
Okay. I
had to guess.
So chewing on your thumb, okay. Sucking on your thumb, as a baby, bad. We don't. Okay. It's good to know. I wanna jump around a little bit then.
Sure.
Because I know that one of the things we've talked a little bit about how your profession has evolved over the last 5 years, over the last 10 years, and a disease that I know is growing in awareness and growing in the prevalence in the population is EOE. I have a adult friend who has that. I've got a member of my nuclear family who has that. So can you, first of all, explain to folks what is EOE?
Sure. So EOE it's short for eosinophilic esophagitis. So this
And what is that?
yeah. So this became recognized. I think it was in the mid 90s where this was recognized. So it's a still relatively new diagnosis, but it is a chronic immune system disorder. So chronic meaning you can never get rid of it. You can medically manage it, but you can never get rid of it. Where eosinophils, which is a type of white blood cell, start to attack food or different foods, or even environmental allergens, or reflux even, and start to build up in the lining of the esophagus, which causes the esophagus to either become irritated or even inflamed. So when this happens, you'll see, a lot of symptoms that are very similar to reflux. And so typically when we see an individual with these symptoms, we start with reflux medication, and often that won't help. So when that doesn't help, we request a scope to be done by GI so they can go in and biopsy the tissue of the esophagus and see if there is a presence of eosinophils there. So once a diagnosis is made, then you can start to navigate, food elimination and different medications, anti-inflammatories, that sort of thing, to try to manage it holistically.
Okay, so there's a lot in there to get into, I think. Is it rising in prevalence just because we're learning more about it and because it's new? Is it rising in prevalence because, I don't know, there's poison in the water? Like what, what is the, why do you think, and understanding that you may not be the research expert on this, but, and is there a reason it's growing in prevalence, or is it not really growing in prevalence? And it's merely been, as you mentioned, it's been people who think they have reflux, but we didn't know about this other disease, and that it's really that they had that other disease, the EOE, all along. What's the reason for the increase?
Well, we ask this question about a lot of different things in our field. So, like tongue ties being one of them. Like, are we just over identifying now? Is it more prevalent than it used to be? Or like, what's the issue? So it's the same with EOE and quite a few other diagnoses, actually. So I think it's a combination of things. I think with EOE specifically, we have historically chalked it up to reflux. Because reflux can also irritate the lining of the esophagus. causing inflammation, causing pain. So it's very easily masked, by reflux. So I think that the awareness is still emerging. I think even myself, like I didn't quite understand this until about 5 years ago.
Mm-hmm.
So I think all of us clinically are trying to understand how to red flag this and when to refer appropriately.
Mm-hmm.
So I think that, that is going to emerge even over the next few years. But yeah, I think a lot of these patients got missed historically.
Okay. And to clarify this, while we started on pediatric disorders, because that's where you have your most enjoyment
Yes,
and engagement in your career. You're capable of treating all ages, and EOE is both, right?
it
It's
is.
all it's an equal opportunity disease.
It
Is
is.
correct?
Absolutely.
Okay. And so if some let's talk about that
Mhm.
to try to help again, just raise an awareness. If you are an adult, you said one of the things is if you've got reflux and maybe you're not as responsive to the medicine, how do you find out is there a gatekeeper to get to a speech pathologist to ask these questions? Do they have to go through their family doctor? Like, how do they get to the right processes to go, wait a minute, I thought I had reflux, but the medicine never seems to work. I'm taking 37 tums a day, plus I'm on omeprazole, plus I'm doing this, it never seems to work. And they listen to this and they go, oh, maybe
Oh,
there's something else that I've got. And because it's new, maybe my family doctor, maybe they're not up on it. I mean, doctors can't stay up on everything. There's so
sure.
much emerging research.
It's true.
How does an adult go and get to figure this out?
So in a perfect world, I think you kind of alluded to the answer there in that primary care providers or PCPs would kind of have a great understanding of this
Mm-hmm.
disease, and they don't, and it's something that will emerge over time, I believe.
Mm-hmm.
So I think, and I have a friend who is in his early 60s who is having this sort of issue where, especially with like meats and breads, you're swallowing and feeling like it's getting stuck.
Mm-hmm.
When food is getting stuck in your esophagus, you often feel it up higher when it's not necessarily stuck right here. This is called a referred sensation. So a lot of times the food is actually stuck a little bit lower, but you feel it like as a globus sensation up higher. So this friend of mine, he went to his primary care provider and said, he's having issues with his esophagus. He ended up having a scope and they did an esophageal dilatation, which is very common, where they go in and kind of stretch the esophagus. But if that's not helping and reflux meds are not helping, then, you know, I I personally wish that we would go in and scope these patients and do a biopsy first to make
Mm-hmm.
sure that we don't have EOE going on before we go into esophageal dilatations, because my understanding of EOE is that over time, with all of that irritation and swelling and all the things that happens, that can cause um, the esophagus to become like strictured. It's not expanding like it should. So the natural thought process is to go in and do a dilatation and open that esophagus back up. But if we aren't addressing the root of the problem, which is could be EOE, then it's just going to keep happening.
Mm-hmm.
So I encourage one of this friend I'm talking about to go and talk to his primary care provider and request that he be seen by a GI specialist to have a scope where they biopsy his esophagus.
Okay.
So kind of leading the primary care provider in that direction.
Okay. And for pediatrics, for kids, is the process different or is it basically the same?
It's basically the same for these kids. Primary care providers are not going to jump to this conclusion. So, fortunately, a lot of these kids do get to a feeding therapist, or,
Mm-hmm.
at least those who have proactive parents will get to a feeding therapist. And the feeding therapist will do sessions with them. And over the course of a couple weeks, maybe we'll start to question EOE. Once the
Mm.
therapist starts to question EOE, they will get into contact with the primary care provider and say, hey, listen, I really think that we need to look into EOE. So it's a little bit of a different pathway because that's often encouraged by a feeding therapist in a child.
Okay. And how is it? I mean, is this sounds like it's treated differently in terms of treatment. Once you're diagnosed, it's treated differently than reflux because obviously, if the meds don't work,
Right.
and that's maybe even one of the ways to sort of diagnose it or to self-diagnose it, or at least get
Sure.
started on the pathway.
Mm-hmm.
How is this treated?
Sure.
Are there easy ways, or is it all? I mean, you're talking scopes and biopsies. That's relatively invasive.
It is
How do you
invasive.
deal with this?
It is invasive. So the initial biopsy, so what's frustrating in anybody, but specifically in children, is that you have to put them under anesthesia to do this, to do the scope, which is daunting for parents to
Mm-hmm.
have to do this. So, they do the scope, they do the biopsy, it comes back that the child has eosinophilic esophagitis. There are different pathways to treating this. For adults, well, actually individuals 10 and older, there's one drug that has been approved for treatment of EOE. But for the rest of the individuals, specifically children, they are often going to do a course of anti-inflammatories, trying to get that tissue back under control. They're
Mm-hmm.
going to do some pretty strict like elimination diets at first, trying to get the eosinophils under control
Mm-hmm.
and trying to determine what exactly is triggering these eosinophils to, gather in the esophagus. So that might be the theories are gluten, dairy, soy, and I think there's one other one, egg, I think. Yes. Gluten, dairy, soy, and egg
Mm.
are likely the most common triggers. So they will often eliminate those four ingredients at the beginning and then slowly add them back once they feel like the esophagus isn't as irritated and see how the body reacts. So a lot of it for children is trial and error, just, because we can't necessarily put them on these medicines that aren't researched for children.
Right, right. And what's interesting to me about those sort of food triggers is how many of them overlap. It sounds like about half with the
Yes.
triggers for reflux, and
Yes,
so
absolutely.
it's just fascinating.
It is.
One of the things that I in some of the questions, the potential questions I sent over to you, I didn't have this one, so I hope you don't mind me asking this one, which is, in the last few years with the original COVID and then the lockdowns and so forth, so much of healthcare tried to move to remote and has since gone largely back to in person. Is your profession one that can be done remotely? I know I've seen some companies starting to emerge that are trying to do this, and I'm not asking you, if you don't believe in it, to cast any stones at those
No,
companies,
no.
but are there some or all of what you, I mean, I imagine some of it has to be in person, but others, are there other things, so if somebody's in a rural area maybe and there's not a good, speech pathologist nearby, can they still get help?
Great question. So when the world fell apart and we started doing virtual visits, even our facility provided telepractice.
Mm-hmm.
So we were able to do sessions virtually, which it honestly, I thought it was going to be horrible because usually I'm working very closely with the child and modeling. I eat with them. I
Mm-hmm.
show them exactly what I want them to do, and it's all about relationship building, and I need them to trust me, and I really
Mm-hmm.
need to have like that face-to-face connection with them, and
Mm-hmm.
using a mirror and doing all these little tricks. But it wasn't horrible. I felt like I was able to still do my job. I felt like I was able to still target the goals that I needed to target. And I feel like I could still definitely help children in that manner. However, the challenge we're running into now is reimbursement
Mm.
for that type of service. So a lot of insurance companies now are not allowing us to do telepractice for our specific services because they won't cover it now.
Hmm.
So that's a bummer because I feel like there are lots of kids I would love to help in that manner, but they won't get paid for.
Yeah, that is a bummer is probably the minimal word. And I live and breathe in that dollars and cents space of healthcare, and it can be very frustrating sometimes. And particularly hearing that, because I wasn't sure what your answer to that question was going to be. I thought it might be, no, it's really a garbage solution, or whatever. But it sounds like it could be an 80% solution for folks. And if they can't get to an on-site visit, if they
Yes.
can't get to a good therapist in their area, a speech pathologist in their area, if they can't, find what they need to get the care for themselves or for their child,
Mm-hmm.
um, I it feels like to me we should, as a industry, figure out some way to do
Sure.
that. But particularly because I leading into where I want to go next is
Hmm.
most healthcare professions are facing a shortage of workers. Is your field any different?
No, no, we, we are definitely facing a shortage of workers. So, and so if you look at the field of speech language pathology and how many of those therapists are actually trained to do feeding therapy, it's
Mm,
it's a very small amount. So
mm,
it's a relatively low percentage of speech pathologists or occupational therapists that are trained and comfortable to provide this type of therapy. So not only do we have a significant shortage of speech pathologists, the number of feeding therapists is incredibly low.
mm,
So in my team, in my outpatient team, we have a very young team. I have been training two of my SLPs to be doing this type of therapy. The training can take a while though. And I mean, up to a year before therapists are really comfortable seeing patients on their own.
mhm.
So it's a big challenge. It really is. If I could see them all myself, I would, but I just don't have enough time in the day.
Is a contributor to this, so doctors, medical doctors,
Mhm.
DOs, they have, to me, a continuing branching of specialties and subspecialties as the knowledge of medicine increases. And I wonder, as we're talking, is that a phenomena that's essentially creating a supply side problem, a human beings going into this field problem for you as well, which is 20 years ago, let's say, or maybe 30, maybe I'm not going back far enough, but hey, I'm a speech therapist, and
Mhm.
we go back to the beginning of our conversation. I teach people to talk, and now there's 10 different things, let's say, that your profession is doing. Is that branching into subspecialties creating part of the staffing challenge?
Well, funny you bring up like 20, 30 years ago because when I decided to when my mother kind of pushed me into this field when I was, a senior in high school, I honestly didn't know what
Hmm.
all it entailed. And I
Hmm.
still think that that is true today, that there isn't a lot of awareness about what all this field encompasses. So when I
Hmm.
started out, I thought that, you work in a school with little groups of 4 and work on your R's. Like I didn't even know. And then as I went through school, I didn't get introduced to I mean, I guess I was introduced in undergrad, but I didn't really get any sort of instruction until grad school. And it was with adults, you get an entire course on it. But in pediatrics, we only got 1 day of instruction on, and it was specific to NICU.
Wow.
So I got no instruction on pediatric feeding and swallowing disorders in general. And so I just had to learn it all on my own when I was done. But yeah, but but for your question, yes, I think that as we move into subspecialties, it creates a major staffing challenge, you know?
Hmm.
So for me, if I were to go look for another job, um, I would have no trouble. I mean, a lot of, no speech therapist is going to have trouble finding a job right now, but being specialized in pediatric feeding and swallowing disorders is something that's highly sought out right now.
Right. Right.
So, yeah, it's like, I don't even know how to go about guessing. Probably like 1 in 250, if I had to guess,
Oh, wow.
are able to do this.
So let's talk about that. Talk about the career as a profession, getting into the career. I always like to talk careers at the end of my interviews, and we're into the last third of our time. So I think it's a good time to talk about that. What does it take to become a speech pathologist? You've got a bachelor's degree, you've got a master's degree, you've got a whole bunch of letters after your name that we joked about during your intro. What does it take? Do you have to have all those letters, or did you volunteer for those? What's required?
Good question. So a lot of the undergraduate programs are either, speech pathology and audiology or communication sciences or something along those lines. So you get a bachelor's degree, and then you have to get into grad school. You have to have a master's degree in. So a lot of times what happens is, like in undergrad, you learn speech pathology and audiology,
Hmm.
and then you have to choose one and go down that path.
Hmm.
So if you're going to become a speech language pathologist, which I believe 95% of undergraduates choose speech pathology as their path, then you have to do a master's program. If you choose audiology, then you have to go and become an AUD. I think it's AUD, and it's a doctoral program. So I think what's interesting, and I just had this conversation with a friend a couple weeks ago. I think what's interesting about this is, like, the undergraduate programs will accept, let's just say, 50 students into this field of study.
Mm-hmm.
And then their graduate schools choose 25. So not everybody who goes into this field of study as an undergraduate and actually gets a bachelor's degree will get into grad school.
Hmm.
So about 50% of people who really want to do this won't get in.
Hmm.
So it's always a little bit stressful when you start applying for grad schools, because you have to apply to multiple unless you're like, the number one student.
Sure.
Because it's kind of scary because you might not get in. And so 1 out of 2 gets to do it. And then you do a master's program, which is 5 semesters. And then once you graduate and get employed, then you have what they call a clinical fellowship. So it's another 9 months of being one-on-one with a mentor, just so that you can continue your training and have people review your reports and get a little bit of support in your first 9 months.
Hmm.
So that's the basics. So that is the MACCCSLP part of my credentials. Okay. So essentially, everybody who does that entire pathway and finish their clinical fellowship, they're either going to be MA or MS CCCSLP. So I decided to do the elective 3-year program to become a feeding specialist. And it was a lot of work. 100% worth it for me, just because it was my obsession and my passion.
Right.
Then I also went back and did the course to become a certified lactation counselor.
Mm.
So for a while there, I had another 3 more letters after that, but have since dropped that certification just because it's I can't keep all of it up. So, sure. But that's the basics.
Okay, so it's a relatively long journey if this is a profession that somebody wants, and from an individual's perspective, a student's perspective, it can be intimidating in terms of the filtering between undergrad and grad school. But as a existing expert in the field, as a business owner in the field, isn't that good to have a pretty assertive level of filtering? Doesn't it make sure that people come through this, they actually want to be there, they want to be in that field? I mean, if the grad schools were just taking everybody, Yeah, you'd have more candidates, but wouldn't I would think that would mean more junk candidates,
Yes,
right?
absolutely. You're absolutely right. And you know, in our department, in our speech pathology world, we strive for a very high level of excellence. So
Mhm.
we provide mentorship long after the clinical fellowship is over because you can't learn everything you need to know in school and then 9 months worth of clinical fellowship. So
Mhm.
yeah, it is very helpful that if you've if you've made it through the graduate program, you're likely a decent SLP
Mm.
and have the potential to become an amazing SLP with a little bit of guidance. So yeah, I do think that it is a good thing that they're selective. I think for us, it's just becoming harder and harder because it's a relatively female dominated field,
Mm.
and the historical trend has been, they graduate at age 24. A lot of time they're getting married in their mid to late 20s, and then start having children. A lot of the females choose to stay at home for a period of time while they're having young
Sure.
children, and that has always been a challenge for staffing when we lose those women for 5 to 10 years as they're staying home with their children, which is
Mhm.
wonderful. But and we have really tried to develop our company around making things flexible for women
Mhm.
who have families. So, we definitely do whatever we can to help them navigate that. I think now, post COVID, we're having more and more issues with people leaving the field entirely, especially for any sort of job that they can do from home. So they're
Mhm.
not even necessarily. There are some telepractice jobs that can be found now, but a lot of them are just wanting to do something entirely different so that they can work from home.
Yeah.
And there are a lot of opportunities for that these days.
Yeah, and I don't I don't think that's limited to the speech pathology world. I mean, there's a lot of folks I think
Yeah.
in that boat who have seen the flexibility and seen the and I think there's a lot of companies who've seen the value of enabling workers to be home. I'm not going to
Absolutely.
say requiring because I'm not a believer in one size fits all approaches to remote versus on site staffing. I think, and that's a whole separate conversation. And I know Dave Kushan and I talked about that in an episode about remote work and so forth and hiring and recruitment. But I think you have to bring nuance to the table. So it's good that sounds like your company's trying to do that. I want to continue to talk career, for advice for folks getting into the field, but I do want to hinge on one thing or go back to one thing you mentioned, which is you try to focus on excellence in your practice and in your company. And I've been, I can't recall if I've had this opportunity with any of the doctors that I've had on, but I've been thinking a lot about this for various medical professions. Those of us who live in the healthcare industry feel like we know what a good doctor, a good nurse, a good speech pathologist looks like if that's our field of expertise. But if you're a patient or the parent of a patient, you you might not know. It might seem like somebody's good, or they might seem like they're bad, but really they're fine. How can the customer
Mm.
of yours, whether that's the patient or the parent or the family member of a patient, how can they judge if they're they hear this, they go, oh, EOE, I need to go investigate that, and they go and they want it investigated, but how do they know if they're being treated according to the guidelines or whatever the case may be? How do they know if their care team is also striving for excellence?
That is a really challenging question to answer. So in our field, we have some really interesting specialty programs. So,
Mm.
for instance, we do modified barium swallow studies for birth to adult. And one of the things that I think is really important, like specifically with this study, is that you ask what protocol are you using? Like, are you using a standardized protocol? And if not, why?
Hmm.
So when you're going to have, testing done in any speech, realm, so if it's articulation, if it's language, if it's swallowing, if it's like, what protocol are you using? Is there, I know this is kind of getting into the weeds of it, but is there inter-rater reliability? Is there intra-rater reliability? For us, that's really important. So for instance, if we are going to be doing a modified barium swallow study, we are using the one standardized protocol that there is,
Hmm.
which is called the MBS IMP. So, I encourage other, patients, parents to ask those questions of other facilities when they're getting these tests done. Like, what are they doing and why? And if they don't have an answer or they can't explain their answer, then be wary. So I think that this is true among a lot of the areas of the medical field. If they can't explain their process and um, their protocols, then you might want to run away.
No, I think that's very fair. And the question comes up more in my mind recently because I think our industry has some work to do to regain the trust of the populace. We've lost some of it over the course of COVID. For good or ill, regardless of your politics, the bottom line is we've lost levels of trust. And so I think that we should be prepared to answer those questions. And I think that
Absolutely.
customers should know what the questions are to ask. And we should, part of our job should be to help them know what questions to ask so they can ask us, and so that's why I wanted to take the opportunity to ask that question. Let's wrap up with if somebody wants to either switch careers and get into, you've talked about what it takes, but if they either want to switch careers or they're just starting on their first career, they're a high school student, they're a college student, and they want
Mhm.
to they like the idea of helping people talk, helping people eat, dealing with all the disease states that you help people with. What advice would you have to somebody in either of those situations?
So for me personally, I think what kind of changed the game for me was doing like a summer internship program at
Hmm.
Mary Britann. So I was very fortunate to have found this summer, internship. And it's by the way something that we are still doing because we
Hmm.
feel like it's very, very important. But as a student, if it's something that you're interested in, we love teaching. We are teachers, specifically Kristen Lang and myself. We love to work with young students who have a passion for this. We also want them to know what they're getting into. So, if you come and you're like, I really thought that I would love this medical, aspect of things. I thought I wanted to work in a hospital at bedside with patients, and who you have to suction them and they're like, it was not for me. Like, it's better to know that early.
Right.
But my advice is to connect with, a speech pathologist and come and observe. Even if
Hmm.
you aren't doing an internship, do some observation hours. We
Hmm.
love to bring those students on, throw them in a lot of different areas, pediatrics, adults, modified, voice studies, all sorts of things, so that you can get a real world feel of what this job entails. And then that can help you make decisions for your future.
Okay. So if you're out there, you have an interest, this has piqued your interest in this as a career, or you've got yourself or some relative who's struggling to figure out what their passion is, what's right for them, reach out in your local area, find some
Yes.
place where it might be have some observation opportunities. Sounds like, and I would assume as a profession, you're all of you, not just you, are open to trying to educate folks. Given the staff shortages we talked about earlier.
Yes, absolutely. And some people have more interest in schools. And
Mhm.
so to see what that is like day to day is very important. And like I said, our profession works in acute care, in the hospital setting. So at bigger hospital groups, they're working in the hospital every
Mm-hmm.
day with those patients who have just been in a car accident or just had a stroke. And so there's a lot. I think one of the things I love about speech language pathology is that there are so many opportunities within it.
Mm.
You know, you can work at a preschool, you can work in a school, you can work in outpatient, you can work in inpatient, you can work at a nursing home, you can do home health. Like there are just so many different opportunities that, you know, even if you get into one area of the field and you're like, you know what, this isn't for me, you have so many other opportunities to, you know, switch it up.
Right. Well, that makes a lot of sense. I think that is a great spot to wrap up. Hannah Hawke, thanks for coming to speak to me and to the audience about your field, about some of the new and emerging disease states that are out there that maybe are masquerading as reflux, as well as educating on what your field can do to help, you know, new babies and young kids if they're having trouble. If you're listening, I hope you stuck in there through the whole thing and learned something. But thanks, Hannah Hawke, for joining me on No Bad Questions.
Thank you for having me, David Kelly.